And we're not doing bad on time, so Dr. Shetreat-Klein, please.
Hi, I just want to thank you all for having me here and giving me the opportunity to react to these really amazing talks so far. There's so many different things to react to. I just want to confirm that I have 60 minutes to react to everything we've talked about so far.
There's a literacy problem we might have discovered there.
Numeracy.
Yeah, numeracy. Yeah, so be specific about it. Fine, numeracy problem. Sorry, I think you have 15 minutes.
So for that reason, I prepared some slides last night, and I'm going to not show or talk about them at all because there's just so many things that came up off the cuff as we're talking that I'd rather discuss. So basically, right, I'm a frontline provider. I work in inpatient, I work in ambulatory, and because I work in rehab medicine, I actually am the recipient of 5 or 6 discharge summaries, per batch of admissions that we do, because I get patients coming from acute care hospitals over to rehab. So I see the good, the bad, the ugly. Most things are in either the second or third category for the most part. And it was seeing all of this that actually drove me to get involved in working with the IT team and trying to make things better. And that gives me some insight into kind of how have we gotten to this place. We all recognize, I see when they show discharge instructions up on the screen, and I was going to show slides of a whole bunch and explain why they look like that, I see everyone's head shaking. Oh, this is horrible. So how did we get to this place? And I think I was going to talk about I was asked really to look at the technical reasons. Can the EMR do this? Can the EMR not do this? Why are we constrained in this way? But frankly, it's not so much the technical limitations of the EHR that are doing this, and it's not so much that meaningful use has required and the EMR people are doing it wrong. Most of what we see in people's discharge summaries really is a collaboration between providers and the IT folks trying to do their best with the tools they have. And it's not always a limitation in the tools per se. I think that even if we came up with what would the ideal discharge summary look like, and let's make the electronic record give it to you, that we would still come up with the same problems. And the reason being, I'm going to quote Dr. DeWalt, and I'm going to use that now in every single talk that I ever give from now on. And I thank you for allowing me to have the tagline of the Institute of Medicine Roundtable says it is not an IT problem, or it's not an IT solution, because it's not just there. The automation, the desire to get the EHR to solve these problems is to a huge degree what causes these problems. Automation is very much a double-edged sword, and it's a combination of the automation and, to be frank, the fact that you get what you ask for, the fact that there are guidelines coming out constantly and regulations coming out constantly and policies being promulgated that say these are the things you should have in your discharge instructions. All right, so we'll throw them into the discharge instructions. When you combine that drive towards provide more information, as Dr. Dreyer said, there's too much information. You combine that with a desire to automate the whole process, that's how you end up exactly with what you see on the screen. And I'll go into more detail with that. Dr. Seidman started off by demonstrating that Gary Larson always gets it right, even 20 years before the development of EHRs. The ginger slide, blah, 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 ginger, blah, 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 ginger. And informatics deals with the right information to the right person at the right time. That's what we try to do. We are doing better at that in terms of giving information for clinical decision support within the EHR to providers who are working to care for patients. We're not doing such a great job with it in terms of the interaction between the EHR and the patient, because the right information at the right time would mean being there when Ginger is about to get into the garbage and saying, Ginger, no, we just got a dog. So I know that's how it works. It's the minimal amount of information, but the right information given at the right time. And instead, what you'd have is, people coming to IT and being like, the dog is really strewing the garbage all over the place, and the dog is at risk because of chicken bones. We need to get some instructions over to the dog, and we'll be handing the dog a 15-page packet with reasons why it is bad to turn over the garbage, a list of items that are in the garbage that dogs should never, ever have. There's chicken bones and coffee grounds, and that's what document would get to the dog. And that's exactly what you're asking IT to give, is make sure they get enough information so that they don't get into the garbage anymore. Now, I realize that's probably too paternalistic to apply Ginger No to how to care for patients, but to a degree, I think a third component of where the problem is the whole shift from paternalism to patient autonomy. And autonomy and automation are really related to each other. Initially, doctors and providers felt, well, giving patients autonomy is going to be a bad thing. Then it's looked as, well, it takes the burden off you. Now all we have to do is give the information. So someone's going in for, an aneurysm clipping, give a list of risks and benefits to an aneurysm clipping. That's going to have obviously tons of technical information that neurosurgeons spend 6 years in their residency and then the next 30 years in actual practice trying to figure out who is the right candidate for the right procedure and what are the risks and benefits. And now we give it as a handout to a patient, expecting that that's going to be a realistic way to give information to somebody, when of course it's not. And you have the same thing in the discharge instructions. We want to give information, but it's not an IT problem. It's not a question of getting the right information on the discharge instructions. It's really a question of changing the process of discharging. And I think that Dr. Williams' examples of the boost discharge form and the patient checklist, and this is the first time I was seeing those are great. And part of why they're great is because they're not part of the EHR. They can't be generated by the EHR. And when you told me you were spending 7 years trying to get them in the EHR, I say, no, keep them out of the EHR. Maybe get a summary in there, but they're all blanks. They're all areas in which a provider has to actually write information onto the form. And it's that process of thinking, what does this patient need, that provides beneficial information rather than a garbage in, garbage out kind of discharge summary. And the checklist that the patient does, the providers can't short circuit that. One way that people might have done this is by creating a checklist in the EHR saying, I reviewed the medications with the patients, I answered all the questions, I did all of that. Well, there's an axiom in medical care that if you've got 40 patients to see, you're going to do things in the shortest amount of time possible. Okay, so it's actually easier to check off the boxes than to go ahead and have those conversations with the patients. And in the end result, unless someone's standing over your shoulder, you're going to do that because you can. So giving it to the patient to check off those boxes in the presence of the provider, that might actually make a difference. Removing the automation and the automaticity from the process may help some of these things. And some of the things that we did at Mount Sinai are really about changing the process. When we're trying to attack the 30-day readmission rate, they developed the PACT program, which basically identifies, and it uses IT tools to do this. It has IT algorithms that go into the medical record and pull a lot of information combined with some human aspects and identify patients at high risk for readmission, and then assigns them case managers and caseworkers who stay with them for 30 days. The next project's going to have to be 31 days after readmission, because that's when the social worker falls off the project, because that's what the regulations wanted you to do. But it's a step in the right direction of getting things in there. I might have rambled. Where am I on time? Okay, so examples a little bit. The Rory Staunton case is in New York, the impetus now for what are called the 405 regulations that just came out in December. The FAQ on it came out maybe a month and a half ago, and it's made for implementation March 31st. What they're going to want is a communication of critical lab values to the patient at the time of discharge because of this CBC, this blood count aspect that was not followed up on correctly, as well as a dictate to provide all diagnostic studies to the follow-up provider. Now, we have until March 31st to figure out the best way to implement that. We've had a number of meetings to try to determine this. We don't even know exactly what are the minimum requirements if we're trying to get to a less is more. So what we're going to end up with is taking an after-visit summary that's already 14 pages, as Dr. Federman showed at Mount Sinai, and we're going to now start adding in lab information. And we're going to do that in an automated sort of way, which is our choices are going to be either show all the labs from the encounter. Well, if you had a 3-month encounter, that's going to be 65 or so pages of labs. And it's going to be CBC. You're all at the IOM. Does everyone actually know what a CBC consists of and what the components are and all that? Well, that's what it's going to say HGB, HCT, RGB, WBC, and there's going to be numbers there. That's not necessarily going to improve the readability of the after-visit summary. In my opinion, it's going to make the after-visit summary worse. We are also, because of meaningful use, trying to create a summary of care document that gets automatically transmitted to follow-up providers. This is a good thing. I think this is actually going to help things until we start to satisfy the 405 regulations that say we have to provide, whereas to the patient, we're going to have some flexibility of determining what is critical lab values to provide to the patient. Now we're going to provide all lab and diagnostic studies, which means that instead of the 10-page document of a summary of care that has a whole bunch of regulatory requirements, now we'll add on the 65 pages of lab studies. And what is the provider going to do when he gets that? You know, there's better answers to that, perhaps, but the you get what you ask for is part of what is driving this procedure. So that was one half. Automation, I think, is the other half. Anytime you automate something, you have as much chance for putting in bad information as you have for putting in good information. So on after-visit summaries, medication lists and problem lists and patient education, those are all things that will get pulled in automatically. As a result, you're going to have a lot of errors. And an AVS that I looked at last night from a New York hospital on Epic that wasn't Sinai had insulin 4 times on the medication list. Presumably that's because the patient was on the sliding scale in the hospital, and actually in the hospital had 4 different insulin orders, which is its own problem, but now it's going on the after-visit summary in the list of medications. You want to automate what Epic recommends in its default after-visit summary that most institutions use is a section for start these medications, these are medication, continue these medications, change these medications, stop these medications. It's great in theory, but it's automated. So therefore, it depends on the actions that the provider takes during the course of the stay, and then the EMR goes and tries to figure out how to categorize all the medication decisions during the hospitalizations into the correct buckets. Now, I barely understand exactly. I have to do a lot of forensic reverse engineering to figure out what were the things that the provider did that ended up putting something into the right bucket. The providers don't really see the after-visit summary. The nurse is the one who distributes that to the patient. So they don't even get necessarily how the decisions of, do I click on the Lasix that is in the prior to medication list, or do I just order Lasix, which is somewhat easier and faster, on day 3 of admission? Well, if I order Lasix on day 3 of admission, and the Lasix was on the pre-admission medication list as well, then you might end up on discharge with stop this medication, Lasix, because that was the home medication, start this medication, Lasix, because that was the medication that was prescribed in the hospital. And because it's automated, that's just what's going to happen. And that's what we wanted. We didn't want people writing down the medications that the patient needs because that was prone to error, it was felt. But we got rid of the 4 sections, and we just have a take these medications, do not take these medications list on our AVS, and even that is prone to error. I think I'm out of time, even though I can talk more about the specifics, and if anyone wants to talk more later at lunch or after, I'd be happy to, but I'm out of time.